start. And what I'm going to be talking about today is the merger of two technologies, epidemic compartment models and correction for measurements. And the time is ripe for doing this. Well, this is why our work is important. In fact, the work of this whole program, the work of the showcase today is important. Infections continuing to grow. And the population policy makers need the most accurate forecast of COVID-19 infections possible. And that's what we're going to be showing you today is the way to do that. And we've quantitatively integrated nationwide county level testing all over the US into the UW Institute for Health Metrics and Evaluation pandemic epidemiological model, the SEIR model, at the state level. And we've used it to modify it to work at the county level, and it turns out to be very accurate after we did that. And what we're doing now, what we're focusing on in today's talk is 7-day forecasts. It turns out that our forecasts of COVID-19 levels are substantially more accurate than other forecasts for 8 out of the 10 regions we tested. And the regions we tested, which I'll be summarizing today, are the New York City area and 9 other counties within the states of New York and Florida, from small to large counties with different kinds of trends going on. Our approach can be extended to include other tests and surveys. We'll be working with Facebook symptom survey, but there's other things we could integrate. We'll talk about how much it helped. Our approach has low compute requirements, can likely work with other epidemiological models. And in order to get us there, and I'll have a demonstration of it at the end. In order to get us there, we're going to talk about the technologies behind what we're doing. I won't spend too much time on the math today, except to say that we're bringing together 2 areas that really have not been brought together in a deep way before. One of them is epidemiology, which is the focus of the crisis right now. And the other is information control theory, and they are complementary. Epidemiology provides underlying systems of ordinary differential equations, originally from theories over 100 years ago, or almost 100 years ago, as to how epidemics spread, coupled standard differential equations, ordinary differential equations. Here's the IHME model shown right here, the model that we ended up using. And this is state of the art for projecting disease trends. And what we're going to connect to this is something that's going to make the model more accurate at a local, that is county or regional level, and every day instead of being more accurate in a monthly or weekly rate. And in order to do that, we're going to make use of technology that was first put together by a professor I learned from, Rudy Coleman. And this is him getting the National Medal of Science Award from President Obama. And for the kind of combination we're talking about. And what this model does, what Professor Coleman did, he taught how to beneficially combine models, for example, mathematical models like the model shown here, with measurements, for example, test results for a county area, for a city region like New York. And we adapt this approach to SEIR models, that is the pandemic model being used now, with testing results, survey results, or other daily measurements. And here's a place where this approach got used, which is very well known, a very famous approach, which is really what got Professor Coleman the Medal of Science Award. That was Apollo 11. So the issue with Apollo 11 was to send a rocket up from the Earth, out of Earth's orbit, and make it so it lands in the spot you wish it to land on the moon. That's a really small target. And the spacecraft starts with, that is the rocket ship, starts with ongoing deterministic mathematical equations represent planetary motion from gravity, friction of the atmosphere, things like that, all together set up through mathematical equations. Those mathematical equations don't take into account all kinds of other effects that perturb the motion of the spacecraft. So what happens is, as the spacecraft was heading toward the moon, the way it was planned, and the way it worked out very well since we put man on the moon, was to sense location from measurements that were on the spacecraft, such as sextants, telescopes, sighting places on the moon's surface, accelerometers, other kinds of measurements, which were real-time measurements, which were used to update the equations so you could do course corrections. Course correction after a first hour, another course correction after a few hours. I'm mentioning enough course corrections so you landed in the right spot on the moon, just where you plan to land. This was not an easy task. The mathematics behind this were actually quite difficult, but Professor Coleman solved these problems. And this is the mathematics we have applied to modifying, instead of planetary motion equations, SEIR, epidemiological equations is what we're modifying through course corrections. Instead of them being course corrections, they're test results in different counties. So here's a summary of what we're doing. For example, for the New York City region, or just north of New York City right here, we start with the pandemic or epidemiological model. In our case, it's the IHME SEIR model at the state level, because these models are done at the state level. They're not necessarily done locally because there isn't enough information for those equations. We then apportion what the model predicts in terms of its 7-day forecast, the one we concentrated on, by taking the population of the region we care about. In this case, for example, Westchester County, we divide it by the state population to lower down what we would forecast the level to be proportional or apportioned by that ratio of populations. What we're looking for is a county positive COVID-19 rate. We have a pretty good forecast already coming at the state level. By doing this apportioning, we get a county level. Now, we know that's not going to be that accurate because apportioning itself is not really a perfect model. So what we do is we update that by integrating both the test rates that are coming from the county tests within the New York region, for this case, and we also bring in other symptom survey information, like from the CMU, Facebook survey, UMD also survey, loss of taste and smell, bring that survey data in. We do an optimal correction of the result of the SEIR model every day that gets updated to come up with a more accurate forecast, minimizes the error more. And as we'll show, this actually works quite well. And here's an example for New York City and how well it worked. And I'll summarize the statistics of the error of these, and let me show you what we're comparing here. What we want to forecast is the actual case count. That is, we're using that as a proxy of how much disease there is. It's one of the better indicators we have, though there's others we could work with, but actual case count is shown as a gold line. It's our gold standard we're trying to track. We're showing since April all the way through November for this tracking here. We are actually able to do it for the next few weeks in December, but I'm not showing those today. And this yellow line is simply a 1 week delayed version of this estimate. It's called the naive estimate. Idea of a naive estimate is really not as naive as it sounds. It turns out that it's quite difficult to beat a naive estimate. And people who work in statistics, for example, forecasting stock prices, know that you can make all the claims you want, but until you can show you can beat the naive estimate, you really haven't done much. What the naive estimate assumes is, well, it's much like forecasting the weather. What's the weather going to be like next week? You don't have any other information. What do? You walk outside and you say, well, what's the weather like today? It's probably going to be like today next week. With no other information, it's the best thing to do. In fact, if you assume the underlying process is a random walk, it's the best estimate you can make. It's the minimum error estimate you can make, which is the naive estimate. So we always compare to the naive estimate. It's our straw man model we compare against just to see how well we do. And it turns out for almost all cases we work with, by updating with information from the case counts in the county or the regional area we worked with, we were able to beat, sometimes substantially, the naive estimate. And so the actual, what we want is this thicker gold line. The yellow line is a naive estimate. You can see the underlying apportioned IHME model. Its 7-day forecast is in gray right here. It was too low by a fairly substantial amount, but the overall trend was well tracked. And our model, using updated version of the SEIR model, in other words, we take this gray as a baseline, a mathematical baseline that then gets perturbed optimally based on things like the case count only, which is purple, household symptoms from symptom data, which is the cyan color, and green, which is loss of smell and taste. And you can see that those particular added features took the gray and they moved it to be closer to the gold, and so in fact sometimes very close to the gold. We'll summarize this with a table with pooled results for more days, in other words, looking over all the days of data we have and looking over more counties, more regions shortly in a few slides from now. But you can see that I can't really say right now which of these is the best. I would need to look find the errors over a set of days and sum that error up and perhaps average it. And we will do that shortly. So this is how well we're tracking the New York City region. That, of course, begs the question, that's the largest region in terms of population we work with. What about a smaller population, for example, in New York State? Well, here's Nassau County right here in New York that we tried. The actual case count in Nassau County was this gold line right here. Again, we show the naive estimate, which is simply the delayed version of it, as a yellow line. The underlying gray line turns out to be the IHME, the epidemiological model, SEIR model estimate right here. And we want to be at the gold line, the thick gold line. That's the best estimate we can make. We can see the naive estimate undershot as we're coming into November here. Also, the gray line, which is the IHME model, it undershot, it was too low. But the two estimates, the three estimates that come from the case count only, household symptoms, loss of smell and taste, came closer. Throughout the duration, it looks like it is the closest. We'll again summarize the error over all those days shortly. Now, here's a very different trend I'm going to show you right now. Instead of looking at only New York, we're looking at a trend in Florida. In Florida, most of the cases came up strongly in end of June and into July, and then came down again. And they're coming back up again now. In fact, they're coming up quite a bit in the last few weeks. And so for Dade County, Florida, the IHME model projected that it would come up. It was accurate about that. Did not come down as fast as the cases actually did come down. How well did the different models do? The actual case count, again, is a thick gold line. The naive estimate is the thin yellow line right here. And the thin yellow line, pretty close, but not perfect. How well did our approach do, which was the purple? With the symptom survey, it became the cyan or the green. They all tracked very close to each other, and they came closer to the gold than the naive estimate. Not that much closer, though, and actually the IHME model did quite well for Dade County for this last day here. But if we look earlier, if we look back in September, it actually deviated by a large factor. So again, we can look at the most recent result, but we shouldn't put too much credence on only that. We should look at pooled results over the days we have, and that's what we're going to do next. That's what we're doing now in this table. A lot of numbers in this table, but let me explain what this table is telling you. This table now, and I'm going to show you another table for Florida after this. This is for New York State. It's for 5 different regions in New York State to see how well we did. We're looking at the daily errors over all days we had data for. And we're looking at the sum of the daily squared forecast error. This number, the lower this number is, the better. I'm going to look at New York City region, Albany County, Erie County, Westchester, and Nassau County. The lower these numbers, the better. And we're going to compare our estimates to the naive estimate, which is simply 1 week later is the same as today. And what we see is that the lowest numbers we get for these different things, we're comparing the pandemic, the epidemiological IHME model, to the naive estimate, to something which uses our technique based on case counts every day. We're going to combine it with loss of taste and smell. And we're going to combine it with household symptoms. The best result for New York City over all dates that we tested was the lowest number we got was with the household symptoms. Loss of taste and smell did almost as good. Case count updated did not do as good. So the symptoms were very helpful for New York City. If we look at Albany and Erie County, turns out naive estimate beat the other mathematically derived estimates. That happens. That happens actually surprisingly often. The naive estimate can beat the more sophisticated techniques. Only 2 out of these 5 cases, naive estimate beat them. And the other 2 cases, smaller counties, Westchester and Nassau, the symptom of loss of taste and smell did the best. The symptom of other people in the household having symptoms did the best compared to those. So our best performing is in bold here. The symptom survey for New York State, for the 5 regions we tried, for 3 of those 5 regions, actually 3 of the 5, the symptom survey helped reduce the error in forecasting. Now I'm going to move on to Florida and do the same kind of test. Look at the overall sum of squared error for all days that we tested. And so we've got Dade County, and these are all different counties, Flagler, some very small counties like Flagler County, And we're going to compare the baseline, which is our apportioned IHME model, SEIR model, compare it to the naive estimate, and then we're going to look at symptoms added and simply just case count without the symptoms. And it turns out that for Florida, the case counts without the symptoms did the best. We did substantially better than the naive estimate. It turns out Florida was changing quite quickly. And when things are changing fast in terms of the amount of disease, it's harder to track by just saying, oh, next week is the same as this week. You need to do more, which is why updating with the case count in our optimal way, as per the software we have, did the best. And it did the best for all the counties we looked at in Florida. And it was validated in all these 5 counties. It was less clear that the symptom survey helped. It didn't hurt by too much, but as you look, the numbers are a little bit higher for the symptom survey. Flagler County, it was just a smidgen higher with these symptoms, added symptom survey. So Florida was a little different conclusion than New York State, but in both cases, our approach beat the naive estimate, sometimes substantially. So another way we can demonstrate the utility of our results is through a weather map we can have. We'll call it a COVID-19 weather map. And our ability to forecast for every county means that we can light up different counties and have a map of the US where you zoom in on a particular state and you see what the different counties are doing. And this map, which I'll be able to demonstrate, can use a browser on any computer or mobile device. Colors can become more red as case numbers are projected to increase in a week, green to decrease, and it's helpful for where can I travel this holiday season? What places should I avoid? Where should we prioritize vaccine deployment, for example? So this is something we're happy to demonstrate, happy to share. Here's the web link for this map. And again, I'm zooming in on New York State. We have it for Florida, a few other states available. So our conclusions are, our approach showed a squared error reduction below the level of a straw man forecast. That is a naive forecast for 8 out of 10 regions, often beating the naive forecast by a very substantial amount. In some cases, the mean square of our forecast was reduced by including Facebook symptom survey data in addition to confirmed case rate. Our currently planned directions are to try other signals from the symptom survey and integrate force of infection into the SEIR model, often called the lambda variable. We're going to also work on forecasting hospital admissions and number of deaths. And our question is, can we help advise holiday travel? Can this be used? Can it be deployed, made use of by the public? Can we help guide vaccine deployment? Can we provide early warning of pockets of problems to get vaccines out and make it higher priority? And we also just need some support for our university-based project, and any ideas will be appreciated. So I'm open to questions, and just if you have questions, here's a list of our team you can look at.